Hello, can everyone hear me now?
I can hear you. This is Trish.
Hey Trish, it's Laura. I unmuted everyone. Is everyone able to hear me? If someone else could just let me know.
We've got about 5 or 6 people in the chat box all saying yes. Now we're about 8.
All right, wonderful. Is it clear, Trish?
Yes.
Okay. I will back it up and we'll do round 2. I'm so sorry, everyone. Let me get back to the beginning. I don't know what that was. And everyone is off mute now, so no need to press star 6 or anything like that. I'll just leave it like that for the remainder of the presentation. I'm so sorry. So I'll begin at the beginning. This is Laura Lane. I'm the Deputy Director for Women's Health at the Department of Public Health. And I hope everyone had a very wonderful holiday. Thank you for joining this afternoon our Maternal Hypertension Initiative webinar. We're fortunate to have Trish Witcher to present our hypertensive disorders of pregnancy. So thank you in advance, Trish. We really look forward to that. A few housekeeping reminders. If you're on the webinar, you can enter your name and participating team members in your facility in the chat box. We'd appreciate it. Also, you can use the chat box at any time during the presentation, but please don't put your phone on hold because we can't control that background music. We will have time for discussion following the presentation, and we've received questions related to the P4 measure about how everyone is identifying cases and getting the specific information from the records. So we would love to hear from you about this, but anything else when we open it up for discussion. Okay, our key driver diagram, we have not made any changes to this. So this should look exactly the same to you. Overall, hypertension goals by December of 2021 are the same, and they are reflected here. The AIM hypertension structure measures, which you are also familiar with, have not changed, and we'll take a look at that in greater detail and see our progress from the baseline in just a minute. Okay, the hypertension process measures. For the first quarter of this year, we will begin to report on new measures. So for P2 and P3, there's the implicit bias training for providers and nurses. And also measures P4 and P5 include identifying cases and determining timing to treatment and treatment. So these process measures may be an area that we'd like to discuss further at the end of our session. Or Dr. Kotke, if there's anything you'd like to mention at this time about the changes in measures, please chime in. All right, I'll continue on. This is our data collection tool that was developed to assist you in collecting the data from the records to report on P4 and P5. This graph shows baseline for the structural measures for hypertension for the data you reported for quarter 3. That's from June to September 2019. And you can see the debriefs are in orange, and that represents the most progress with a 74.1% rate of implementation. Measure 4, unit policy and procedure, and measure 1, patient, family, and staff support are very close, right below 40% implementation rate. Okay, our process measures for hypertension. This graph represents the baseline for the process measures that you reported on at the exact same time frame from June to September 2019. And you see the most progress is preeclampsia nurse education, that's the gray bar, with 70.2% implementation rate. And that's followed by preeclampsia protocol nurse education, and then preeclampsia provider education, and then finally preeclampsia protocol provider education. So are there any questions at this time about the key driver diagram, the goals, any of the structure or process measures? I saw something in the chat box that some people are still muted, so if you would like to chime in, press *6 and see if that works for you.
Laura, can you hear me?
I can hear you.
Ah, okay. So this is Missy Kotke. Apologies to everybody because I think there's some nuances going on that are unique to us.
I'm so sorry.
I couldn't unmute myself earlier. I thought that I had a little button, but I didn't. So the *6 is a really nice tip for everybody because I anticipate that many of the folks on the call are going to be muted in the background. So if you need to ask a question, please ask a question or chime in, but the *6 I think is a good way to go about this. We also are seeing some things in the chat box that a couple of people maybe still can't hear. I'm going to mute myself again and then see what I can do on the back end to help those folks, but just wanted to go ahead and try the unmute and see if it works, and I'm delighted that it did. Thanks for your help.
Oh, yeah, Diane did say a couple people still can't hear. Okay. Are there others on the line who can hear in addition to Dr. Kotke, Trish, and I?
I can hear.
Okay, I see in the chat box there are some who can hear. So technology is an issue, but I see a lot that can hear. So we'll go ahead and move forward with Trish's presentation because this is recorded. So as we continue to work on the technology audio issues, we'll let her go ahead, and then if we need to catch up later on the recording, we can do that. Okay, so Trish, I will introduce you with no further delay. Trish Witcher is a clinical outcomes manager for women's services at Northside Hospital. She received a Bachelor of Science in Nursing from the University of Nevada, Las Vegas, and a Master of Science in Nursing as a high-risk obstetrics clinical nurse specialist from the University of Texas Medical Branch at Galveston. Trish has presented nationally on high-risk and critical care obstetrics, obstetric liability, and fetal monitoring, and has published numerous articles in peer-reviewed journals. More recently, she has served as author and co-editor of AWAN's 4th edition of High Risk and Critical Care Obstetrics, which was published in late 2018. Her most recent publications since 2015 include articles and chapters on maternal morbidity and mortality and hypertensive disorders of pregnancy. Trish is also a contributor to AWAN's online courses and webinars, specifically cardiopulmonary resuscitation in pregnancy and disseminated intravascular coagulation. She's chairperson of the AWAN Task Force to develop basic, high-risk, and critical care intrapartum nursing clinical competencies and education guide, and is a member of the Georgia Maternal Mortality Review Committee. So thank you so much, Trish, for being with us this afternoon. I apologize for the technology difficulties, but we are excited to hear your presentation.
Well, thank you very much, and I hope everyone can hear me. I am doing it on my computer instead of by phone, but I think we did a sound check earlier and it was fine. I do have the chat box up. I'm going to do my best to monitor the chat box as I'm presenting, but if I think I'm getting distracted and swayed from the presentation, then I may come back to it at the end of the presentation for questions. But I'll do my best to monitor that as I'm going along. Can I have the next slide, please? So I wanted to just really, this talk is really focusing on the complications of preeclampsia and key assessment and management opportunities that we have, not just restricted to nursing, but these are opportunities for multiple disciplines. But one of the most significant issues that has been identified in the task force report on hypertension and pregnancy, which was published in 2013, was that providers fail to recognize the multi-system nature of preeclampsia. This is not just hypertension with proteinuria, and there's been a lot of work and a lot of publications to work past that paradigm. That has to be overcome, this failure to recognize multi-system nature of preeclampsia, because in order to appropriately manage these patients and evaluate them in order to identify onset of severe features, we have to appreciate that this disease is a very dynamic disease and one that can deteriorate and progress from gestational hypertension to preeclampsia, or preeclampsia that has previously been termed mild preeclampsia to severe preeclampsia. Another big point of emphasis in that ACOG task force report was that mild preeclampsia should be abandoned, because that term in and of itself shows a lack of appreciation for the dynamic and progressive nature of the disease. Can I have the next slide, please? So I wanted to just cover the pathophysiology, and I'll come back to this slide several times, but in reviewing the complications, I think it's worthwhile to have this as a foundation. And I think there's been quite a bit of published about preeclampsia from a model of a maladaptive uteroplacental response to the pregnancy, but there's been more recent publications about cardiovascular implications of preeclampsia, and I'll try to wrap that up and do that as concisely as I can. So can we go to the next slide, please? First of all, just the underlying pathophysiology for the multisystem nature of preeclampsia is the model of decreased end organ perfusion. In order for there to be a successful pregnancy and adequate uteroplacental perfusion, there has to be restructuring and reorganization, so to speak, of the placental vasculature to convert the uterine spiral arteries into very dilated vessels in order to favor placental perfusion and support the pregnancy. In preeclampsia, this invasion into the invasion into the uterine spiral arteries by placental trophoblasts is shallow, and as a result of that incomplete trophoblastic invasion, the uterine spiral arteries fail to achieve that dilated, low resistance state and instead become vasoconstricted. That leads to decreased placental perfusion, which then in turn leads to placental ischemia. And the placental ischemia is believed to be responsible for widespread vascular and endothelial injury, which contributes to decreased end organ perfusion. But also there's an inflammatory component as well. And then there's been a lot published in the last probably 10 years about the angiogenic factors. So for those of you who might not be following the research or the studies that closely, angiogenesis is the term that is used to describe this process of placental dilation, placental growth in order to have that low resistance state. And what happens in preeclampsia, likely because of the placental ischemia, is that anti-angiogenic proteins antagonize those angiogenic proteins which would promote that vascular growth. And interestingly, the anti-angiogenic proteins have also been identified in individuals with cardiomyopathy and cardiovascular disease outside of the pregnancy. But that anti-angiogenesis also contributes to this state of decreased end organ perfusion, and as a result of decreased end organ perfusion, you may see renal insufficiency, decreased hepatic perfusion, placental insufficiency. All of those can lead to the complications that we're going to talk about. And I'm not going to talk about all of them, but the most common and most significant that contribute to maternal morbidity and mortality. Can we go to the next slide, please? So if you look, again, by organ system, these are the organ system effects. I'm not going to address all of them. I am going to talk about eclampsia, ischemic, and hemorrhagic stroke from the standpoint of why we need to be so focused on managing severe hypertension. I'll talk about acute pulmonary edema and heart failure, again, because what's interesting, and when you look at cardiovascular disease and you look at metabolic disorders and you look at preeclampsia, the pathophysiology is there's a very similar model of pathophysiologic processes, again, especially related to these anti-angiogenic proteins. There is the risk of subcapsular hematoma, hepatic rupture, again from decreased hepatic perfusion, which can cause rupture of the blood vessels that are in Glissa's capsule, which can lead to that hematoma formation, which is vulnerable for rupture, which can lead to hemorrhage and hypovolemic shock. Patients are at risk for thrombocytopenia. Even though they are at risk for thrombocytopenia, disseminated intravascular coagulation outside of a hemorrhage scenario, placental abruption is very rare. And then placental abruption is certainly another complication. We see a 5-fold increase in the risk of placental abruption among women with hypertensive disorders of pregnancy. But where I'm going to focus today in the 30 minutes is on eclampsia, intracranial hemorrhage, and pulmonary edema. Can I have the next slide, please? I'm glad that I thought ahead to say that that's what's on the slide, because that's what we're talking about. So we'll just go on to the next slide. So first of all, eclamptic seizure. Eclampsia is the tonic-clonic convulsive phase of preeclampsia. Eclampsia is not considered a subcategory or a category of preeclampsia. It is the convulsive phase. Eclamptic seizures are typically self-limiting. They typically resolve in minutes. They don't take, and really even less than that. But the concern is the period after the seizure is the period of maternal apnea and compromised uteroplacental perfusion, which can lead to impaired fetal oxygenation. What's key about eclamptic seizure is to prevent it, and then if we need to treat eclamptic seizure, to not treat so aggressively to where we completely obstruct the woman's ability to maintain her airway and resume spontaneous ventilation. So if we're looking at someone with refractory seizures that don't respond to the magnesium loading dose or an additional mag bolus, and we're looking at having to give Valium or a short-acting barbiturate, then we're looking at someone who's at risk for respiratory arrest, respiratory depression. So we want to make sure that we have resources at the bedside to intubate and ventilate the patient. Can we go on to the next slide, please? This was a source from 2011, and actually, after I submitted this presentation, I just pulled the Obstetrics and Gynecology Journal for this month, and also pulled the recent ACOG committee opinions, or I believe they're practice bulletins on chronic hypertension and preeclampsia gestational hypertension. And although we see here that on this slide that in 2011 there was an estimate that 20% of women will have a seizure without any kind of premonitory symptoms, what came out in some of these later publications is probably up to 38% of women with an eclamptic seizure have the seizure before any documentation of high blood pressure or other signs and symptoms of preeclampsia. So what's key about eclamptic seizure is there isn't an aura, there isn't anything that warns us that the patient's about to have a seizure. It comes on suddenly and very acute, and in some situations this can be the initial clinical manifestation of preeclampsia. So this warrants close monitoring of all patients. So we'll go on to the next slide, please. I've already referred to the additional anticonvulsant agents in further increasing the risk for respiratory arrest or failure for the patient to resume respiration. So we need to be prepared to support ventilation if we're looking at multiple anticonvulsant agents to abate the seizure. The other thing that we need to be mindful of is that we have to secure the patient's airway before we can proceed to an emergency C-section. We shouldn't be going to the operating room until we've stabilized the patient. We know that we have that patent airway. Next slide, please. So despite everything being said about preeclampsia not having any premonitory symptoms, and often, and in some cases being the initial manifestation of preeclampsia, in 2013, the American College of Obstetrics and Gynecologists recommended against administering magnesium sulfate unless there were severe features. That's not been without controversy, and there are some centers who still administer magnesium sulfate for preeclampsia without severe features, but the current recommendation is to provide seizure prophylaxis for patients with severe features of preeclampsia. The other key management or interventions was to really encourage everyone to continue magnesium sulfate for delivery, continue magnesium sulfate when we transfer the patient to the operating room for the C-section and throughout the C-section. And the reason for that is that I think historically or traditionally, magnesium sulfate's been discontinued prior to transferring the patient to the operating room for cesarean birth, but the concern for that is that's not really going to do any good because the half-life is 5 hours, so discontinuing it to get the patient to the operating room and do the case isn't really going to help with airway management or securing the airway for intubation. And there's a concern that when we discontinue magnesium, we are going to have subtherapeutic magnesium levels, which could lead to eclamptic seizure. And that time of delivery or induction of anesthesia is a physiologic stressor, which can escalate the risk of eclampsia. So that's something that may be relatively new to some of us, that we really should be continuing magnesium sulfate during the delivery and the intraoperative period. Can we go on to the next slide, please? So what's key about magnesium sulfate is that, and I think one of the recommendations, or some of the research supporting the recommendation that mag sulfate should be given for severe features of preeclampsia is that the incidence of seizures in women who were treated with placebo was 3.2% amongst women with severe preeclampsia, compared to about a less than 1% risk of seizure in women with mild preeclampsia. And so, again, some centers still give magnesium sulfate for preeclampsia without severe features. And I say mild preeclampsia, but I'm really trying to say preeclampsia without severe features. But magnesium sulfate is not without risks. However, if we do our due diligence as nurses in our double checks and monitoring the patient for magnesium toxicity, it should be safely administered. And most of the adverse events that we see from magnesium toxicity have to do with not monitoring the patient frequently enough and appropriately. So can we go on to the next slide? That was the basis of the ISMP alert that came out in 2005, that these are the most common errors in administration as far as patient monitoring, pump programming, giving the appropriate infusion. Also, one of the other contributors to magnesium toxicity is when we give the loading dose from the same bag that we're giving the maintenance infusion on, because you're looking at 4 to 6 grams in about 100 milliliters of fluid, compared to maybe 20 grams of mag in a liter. So if we have a calculation error and we're looking at 20 grams of mag in the bag, we're looking at a higher risk for mag toxicity. So there's also been the recommendation that the loading dose be administered from a separate bag and a separate admixture. Can we go on to the next slide, please? So with all that being said, I think most of us are familiar with eclampsia. Eclampsia has been included in many publications with the categorization of hypertensive disorders of pregnancy, but the leading cause of pregnancy-related death is not eclamptic seizure. It's stroke and organ failure. And then we see pulmonary edema being problematic, even more so than eclampsia. So this is why we have the focus on treating severe hypertension in pregnancy, and then I'll talk a little bit about fluid management and pulmonary edema here in a little bit. So if we can go on to the next slide, please. So I want to just talk about cerebral autoregulation. And cerebral autoregulation is basically the perfusion of the cerebral blood flow and perfusion of the brain under a certain or given blood pressure. And so when the blood pressure is within a normal range or a little slightly lower than that normal range, only slightly higher than that normal range, but when we're in this relatively normal range of blood pressure, then we have adequate and appropriate regulation of the cerebral microvasculature to perfuse the brain. When we see elevated blood pressures, we see vasoconstriction, significant hypertension, we have the risk of decreased cerebral blood flow because of vasogenic edema and intracranial hemorrhage. So this is why we have the emphasis of treating severe hypertension, severe range blood pressures to prevent intracerebral edema. But then we have this other end of the spectrum, which would be profound hypotension. In individuals with hypotension, the perfusion of the brain cannot be maintained, and we run the risk of ischemic stroke because of decreased cerebral perfusion. And I will come back to this when I talk about the patient who suddenly has normalization of blood pressure and why that should sound the alert for us when blood pressure suddenly normalizes. But I'll come back to this concept. If we can go to the next slide, please. So the majority of strokes in hypertensive disorders of pregnancy and preeclampsia are hemorrhagic in nature, probably about 90%. But there are a percentage of strokes that are ischemic in nature. The problem with stroke, and it's not like that's the problem, stroke is problematic, but one of the issues with identifying stroke is that the signs and symptoms are very diverse. There's a very diverse range. It can range from something very subtle like headache or visual disturbances to hemiparesis, aphasia, delirium. So we have to pay attention to that patient with persistent headache and visual disturbances. Problem with that is that those symptoms are vague, and many of those patients don't have a stroke, but we can't be reassured by the fact that most patients do well with these signs and symptoms. So if there's any concern about the potential for stroke, if her headache is so severe that she can't hold her head up, she's not responsive to medication, then we really should think about consultation with neurologist or a stroke team to look at neuroimaging in order to rule out stroke for these patients. So if you know the next slide, please. So I showed this slide, I think, on one of the earlier presentations I gave for the collaborative, but I love this slide because these data came out of California, or actually I think multiple states. I believe this slide came out of I can't remember the organization, but it was a performance improvement initiative in a large hospital system. And they looked at implementing standardized treatment of severe hypertension. And they looked at three key things in that standardized management: that all patients with severe hypertension be treated as soon as possible, but no more than an hour after onset of sustained severe hypertension. They looked at giving magnesium sulfate for patients who have severe hypertension, and then a postpartum follow-up within 3 to 7 days after discharge. And they looked at their outcomes based on whether they did all three of those elements or really just treated severe hypertension and focused on that. And you can see their baseline was at about 50 to 57%. And then when they looked at different phases, which were 6 months of monitoring, about a year out, their compliance went up to 90%. So if you look at the green bar graphs to the right of the screen, you see that the incidence of eclampsia decreased, and that was a statistically significant decrease from baseline to phase 2, which was a year out. And their severe maternal morbidities, as defined by the Centers for Disease Control, which are going to be based on diagnosis codes, but the severe maternal morbidities decreased significantly, and that was a statistically significant increase as well. So I like to put this slide out in front of the medical providers to say, look, I understand that most patients with severe hypertension are not going to have cerebral hemorrhage, but you can't predict which patient is going to have that event. And the standard of care is to treat these patients with severe range blood pressures. And this will have impact on our clinical outcomes. This is real. We need to be doing this. We need to continue to emphasize this and monitor it, because if we're not monitoring it, we are not going to achieve the outcomes that we need to achieve. So I'm going to step off my soapbox on that and move on to the next slide. So just so that everyone, we all know this, but what's interesting about uncontrolled severe hypertension and the definition of that is it used to be a systolic as high as 180. Some sources quoted 170, but there was a landmark study in 2005 by Dr. Martin that showed that the systolic blood pressure could be as low as 155 prior to intracranial hemorrhage and stroke. So systolic of 160 or higher, or a diastolic of 110 or higher often precedes hemorrhagic strokes, which is why we're focusing on treating these patients. And that therapy is guided by published guidelines. If you look at ACOG committee opinions and practice opinions, and you look at those committee opinions and practice bulletins over time, you may see a practice bulletin on a certain subject matter. You may see an interim update, but you usually don't see another publication on that same subject matter for about anywhere from 3 to 7 years. What's interesting, if you go back through time and you look at ACOG publications on treating severe hypertension, there have been like 5 or 6 committee opinions emphasizing why patients should be treated and tweaking the protocols and what medications we should be using. So clearly there's a clear priority coming from ACOG to treat these patients as well. So if we can go on to the next slide. So we treat patients' blood pressures. The goal is to get the patient out of that severe range blood pressure. So the goal with treatment is to get her to a systolic blood pressure of about 140 to 150s, or diastolic pressure of about 90 to 105. Our goal is not to bring the patient to a normal blood pressure, not to bring her to a 120 over 60 or a 120 over 60 because of that auto regulation. If we drop her pressures when she's used to perfusing her brain under high blood pressure, then we run the risk of causing decreased cerebral hemorrhage and stroke from decreased cerebral hemorrhage. So our goal is just to get her out of stroke range. When that blood pressure rarely normalizes that suddenly. So when we've had a patient with blood pressures of 140s to 150s over 90s, and let's say she's had a vaginal birth or cesarean birth, and we see blood pressures of 110 over 60, for her, that's hypotension. And just like we would escalate our protocols for hemorrhage and sepsis for a systolic blood pressure under 90, we need to be moving forward and escalating care and evaluation of that patient for the potential hemorrhage or other etiologies for hypotension at a higher blood pressure value than that less than 90 systolic. So hopefully we can go on to the next slide, please. So this is what happens with autoregulation. So if you look at the darker red bar, what happens with patients who, again, are hypertensive is that autoregulation, and I might be saying autocorrelation. I might have thrown that in from fetal monitoring, and I apologize. But that autoregulation curve shifts to the right when she's hypertensive, and so there's cerebral perfusion under higher pressure. So if we drop her pressures to 110, 120s systolic, we're looking at potential for decrease in cerebral perfusion. And again, that's not what we should be expecting. That doesn't mean we've treated her or cured her. We need to be worried about patient. Our first thought needs to be, is this patient bleeding? Is she hemorrhaging? Can we go on to the next slide, please? So I'm going to move on and talk about acute pulmonary edema, because acute pulmonary edema is a significant contributor to maternal morbidity and mortality. So I want to just review the pathophysiology of pulmonary edema. So when we look at maintaining normal intravascular volume, that's a balance between hydrostatic pressure and colloid osmotic pressure. Hydrostatic pressure is the pressure exerted by fluid within the interstitial space, or I'm sorry, within the intravascular space. So it's pressure in the intravascular space, and it would be the force of pushing fluid out into the interstitial space. So fluid overload, decreased ventricular function, those types of things are going to increase hydrostatic pressure and cause fluid to be pushed into the interstitium. Colloid osmotic pressure is exerted by proteins, and so albumin is the principal plasma protein. Globulin, fibrinogen are also plasma proteins, but colloid is the principal protein. So I mean albumin. Colloids pull fluid toward it. So based on how many colloids we have in the intravascular space, those protein particles will pull fluid into the intravascular space. When we have decreased colloid osmotic pressure, either because we have increased fluid, so we can have this with fluid overload where we can have a hemodilutional effect on albumin, or if we've lost albumin because of blood loss, or we've lost albumin because of the endothelial capillary injury where now we have leaky vessels and fluids and colloids escape into the interstitial space, we have less pulling power to pull fluid into the intravascular space, which can contribute to pulmonary edema. And the reason why I go over that is because they are, whether it's a hydrostatic force or a colloid osmotic pressure force, the patient's going to manifest with the same symptoms and same imaging findings of pulmonary edema. And so we have to understand the physiology because it will impact how we manage the patient beyond that initial assessment period. Can we go on to the next slide, please? So again, I talked about cardiogenic pulmonary edema. That's the ability, that's the force that pushes fluid into intravascular space. So if we have increased circulating volume, she's fluid overloaded, then that hydrostatic pressure exceeds the colloid osmotic pressure, which is the pulling. We have more push, less pull, and we can see pulmonary edema. Whereas when we have a non-hydrostatic or non-cardiogenic pulmonary edema, that's from decrease in colloid osmotic pressure, where we lose the ability of colloids to pull fluid back into the intravascular space. This is why administering albumin is you can move to the next slide. This is why administering albumin for intravascular volume expansion in a patient with preeclampsia is problematic, because if we give albumin thinking, well, we're just going to pull all that fluid that's in the interstitium back into the intravascular space, well, the reason why she probably developed pulmonary edema anyway was because of capillary leak, albumin escaping into the interstitium, and so now all that protein we gave her and all that fluid we pulled back in the intravascular space is just going to leak back into the interstitium, and we're probably looking at a worst case scenario for pulmonary edema. So initially, regardless of the underlying cause, we're going to manage and assess the patient the same way. The initial evaluation should include pulse oximetry monitoring, supplemental O2 to maintain O2 saturation above 95%, an indwelling urinary catheter to be monitoring intake and output, because we're going to anticipate that we're going to be giving loop diuretics, so we're going to want to see if she begins to diurese. She may or may not get an arterial blood gas. Chest x-ray should be done very, very early on, and this was actually a recommendation by Dr. Clark and Dr. Hankins in their 10 clinical diamonds for preventing maternal mortality and morbidity. And I'll come back and talk about the B-type natriuretic peptide. Nursing interventions, you want to put the patient in a high Fowler's position. The patient is going to most likely assume this position on her own. She's not going to be able to lie supine without being symptomatic. The reason you put her in a high Fowler's position is because high Fowler's position decreases venous return to the right side of the heart, and it decreases the volume load on her heart and into her lungs. So it's a positional way to promote fluid restriction. Also fluid restriction, and we're looking at gentle diuresis initially with about 10 to 20 milligrams of Lasix initially. She may require cardiology consultation, a cardiac echo, and may require ICU admission for further monitoring and mechanical ventilation. So can we go on to the next slide, please? So BNP, I don't know if you all are routinely evaluating BNP, but BNP is a way of evaluating for a patient who may be volume overloaded. What BNP indicates is basically the higher the BNP, then the more significant volume overload may be, and our concern is that she may have impaired left ventricular function and a decreased ejection fraction, which may be accounting for that. We have peptides, atrial natriuretic peptide and B-type natriuretic peptide, which are markers of fluid overload. When there's fluid overload, there is strain on the ventricle, and as a result of ventricular strain, these peptides are released into the circulation, and then as a result, they promote widespread systemic vasculature relaxation. They increase capillary permeability because they're trying to decrease the burden on the heart. They also promote diuresis and excretion of sodium. And the whole intent and net result is a decrease in cardiac workload. So if someone is fluid overloaded, there's going to be that cardiac strain, and these peptides will be released into the in circulation, and we can measure it in a serum sample, and BNP is not believed to be that much more elevated in pregnancy, so we can use the same parameters for cutoff thresholds that we would use in the non-obstetric population. So for your patient who's got fluid, who's got pulmonary edema, and we don't know, well, is this endothelial capillary leak, and she's just got leaky vessels. If we keep giving her more and more and more Lasix and we dry her out, well, that was a disease process that caused the capillary leak and caused the pulmonary edema. Or if we don't diurese her because she's fluid overloaded, we're looking at congestive failure. So the management, that initial management with Lasix and oxygen supplementation is going to be similar, but then we have to get to a point where do we aggressively diurese her or do we support her with mechanical ventilation? And that's a medical decision and typically going to be made in collaboration with maternal fetal medicine and our critical care colleagues, but a BNP might be a lab value that we can do in the interim to kind of help guide the next bit of management if she doesn't seem to respond to that initial dose of Lasix. Can we go on to the next slide, please? So I've talked about the maladaptive uteroplacental response, and now that we've talked about pulmonary edema, that's a segue into what happens from a cardiovascular standpoint in preeclampsia. So if we'll go on to the next slide. So these anti-angiogenic proteins have been identified or have been measured in women with global left heart strain years after the pregnancy. And so there's some discussion as to whether these anti-angiogenic proteins initiate the disease process or whether they are markers of the disease process that's already going on. And so there's some thought that maybe this, you know, when you look at gestational diabetes, maybe being a precursor to adult or non-insulin dependent diabetes or type 2 diabetes, because maybe there's already a process by which there's a metabolic abnormality, the pregnancy becomes a stressor because that patient already has a disease process going on. That may be something similar with preeclampsia and cardiovascular disease, that there may be some underlying cardiovascular abnormalities that lead to this patient not being able to adapt to the pregnancy and becoming symptomatic. Or do these anti-angiogenic factors promote ischemia and promote the disease process that it increases the likelihood of cardiovascular disease later in life? So that's being studied right now. So we don't know for sure. Can we move on to the next slide, please? Go on to the next slide, please. So when we look at then preeclampsia, especially later onset preeclampsia, that's going to be the model by which we have a maladaptive response. So this process that I talked about with placental ischemia, endothelial capillary injury, is the pathophysiology that's been attributed to early onset preeclampsia or preeclampsia prior to 32 weeks. And interestingly enough, even though the model for cardiac maladaptation is later after about 34 weeks, it's this patient population with early onset preeclampsia and endothelial capillary injury who are at even higher risk for cardiovascular disease later in life. Again, they think because of these circulating anti-angiogenic proteins. Can we go on to the next slide, please? But in late onset preeclampsia, and it doesn't mean that women who present at 34, 36 weeks, it doesn't mean that this is their pathophysiology. It's just this is the pathophysiology that seems to account for that onset more often than not. There is a belief that patients may have because the need to adapt to the increased cardiac output and increased blood volume state of pregnancy, that at some point as that pregnancy continues to advance, they're just not able to accommodate that expanded volume, and they develop hypertension because of a maladaptive response to have vasodilatation and smooth muscle relaxation. And these are the patients who are at risk for becoming volume overload. So I learned, when I first learned about preeclampsia, I've learned they're dry, they need volume, we don't want to fluid restrict them, and now there is more of an appreciation for, yeah, some of these patients may be volume contracted and dry, which is causing the endothelial capillary injury, but some of our patients are fluid and volume overloaded, and we don't want to be indiscriminate in our fluid administration because those are the patients who are at risk for pulmonary edema and adverse outcomes and maternal morbidity and mortality if they're not able to oxygenate and perfuse. Can we go to the next slide, please? So in summary, I just want everyone to appreciate, or if you haven't already, or really you're in a position to educate nurses and coach nurses at the bedside, and I believe that nurses have an influence and can coach our medical colleagues as well. We all have to have a full appreciation that preeclampsia is a multi-system disease, and we have to appreciate that it's a dynamic process. Patients can deteriorate very, very quickly. There can be a very sudden onset of deterioration, which means that when they have severe features, certain severe features are going to warrant delivery. Others are going to warrant close observation corticosteroids and delivery within 48 hours, which is beyond the scope of this talk. The other point that I want to emphasize is that those adverse effects remain after delivery. They don't go away because we delivered the placenta. These adverse effects can persist well into the postpartum period and even up to about 2 years. It can take up to 2 years for blood pressure to normalize from preeclampsia. So there are significant contributors to long-term cardiovascular disease from this disease process. So it's one that warrants significant respect and a high level of concern as the underlying foundation for our surveillance and monitoring and interventions. So that's my last slide. I thank you all very much. At this point, this is a good transition for us to talk about the P4, P5 measures, how that monitoring is going on, and have that discussion. And also, if any of you have any questions about the presentation, or additional comments or something that you've read that you want to share, love to see that in the chat box, or love to see any of you bring that up on audio. Thank you. I'm done.
Thank you so much, Trish. What a great presentation.
Thank you.
So interesting. Thank you. I'm going to just leave the line open for a minute and see if there's anyone who would like to ask any questions or share any of their experiences. I don't see anything in the chat box right now.
So Dr. Kotke, while we're waiting, I know that there's been a lot of discussion about just monitoring the severe hypertension for that measure. And I know that we're having challenges at Northside as well, and we have a nurse champion at each of our hospitals who actually are involved in the data collection who can chime in. We've had some unique issues in identifying patients. We get a report built, but maybe only roughly about 30% of the patients who would show up on a report because of one severe range blood pressure actually have sustained severe hypertension for 15 minutes. And so we are really trying to figure out the best way to identify patients so that we have an adequate sample, but it's not such a laborious process for data collection. And I don't know if anyone has any ideas or anyone has similar struggles.
Trish, thank you for the question. I think that is, and I'm not sure how much time we're going to be able to get to it today, but I think it's one of the most important types of conversations that we have. I think the challenges that you describe are very real, and from what I've heard from folks, and I, again, encourage anybody who's on the line who is actively dealing with this to go ahead and jump in on the conversation, but each labor and delivery unit is unique in how it approaches this. And some places have an IT system that they can query and kind of set up algorithms on the back end for querying blood pressures. some, I know in smaller hospitals are still doing a very manual approach, which may be feasible in certain settings. And then some have other approaches that they're doing as well to try to identify the severe range pressures. But I know from talking with folks at other states that have done this, this is a theme. We're not unique in this way. This is one of the big challenges because so many of us have really complex settings on our labor and delivery unit, right? Like it's the intersection of so many different systems kind of at play. So I don't have a magic bullet, but I think one of the things that we can do is try to support one another with the ideas that we've had, the successes that we've had, and then some of the troubleshooting that we've done. So this is a central question that I think we want to keep talking about. Are there folks who have things to share with the group, things that you've tried, things that have worked? That's so much quiet.
Yeah. Well, so Dr. Scott, I'll just chime in from Northside. And obviously at our Atlantic campus, one of our, one person saying the manual tool for us. One of the things that we've done is we really tried to get an IT report to identify patients. And so what we've done is the system does a good job of identifying a systolic of 160 or higher or diastolic of 110 or higher, and it can give us the date and time of that blood pressure in the report. And then it can also give us the medications and the date and time of the medications. So for those patients who are treated within an hour, we could feasibly look at them without having to do a chart review. But the issue we have is the patient who has that elevated blood pressure, if 15 minutes later her blood pressure is not in severe range, well, she doesn't have severe sustained hypertension, and she wouldn't be treated. She would be monitored but not treated. Our report doesn't capture those patients. So our people who are doing the auditing are having to go back into those records to see what the subsequent blood pressure was, if it was still elevated. And so that's what we're experiencing. So someone says that I'll let you go with what's in the chat response. People are coming in now in the chat room, but we're even looking at maybe just doing our audit, because we have an audit capability to see today or whose blood pressure was this range today or yesterday, and then maybe auditing those more real time, but because we want to make sure we have an appropriate and representative sample.
Mm-hmm. And I'm looking at Haritha Hankins. Can you unmute and describe a little bit more? It seems like you guys are doing a manual poll. You're doing 10 charts each month of people who were treated. Is that how we should interpret your approach? Star 6 is how to unmute yourself if you're muted.
Can you hear me now?
Yes.
Okay. So, yes, we have a team member who sits and looks at 10 charts every month. She uses the problem list to see if their patient was even diagnosed with hypertension so that she can narrow it down to those are the patients she's going to look at. And then we have Epic as our system, and inside of Epic you can look and see what the flow sheet shows you as the blood pressures, looking at the graph. And so if she sees one that falls out of range, which is pretty quick and easy to see on the graph, then she immediately goes in, sees whether or not it was done within 15 minutes or 15 minutes or more. Did they recheck it? Was it still high? And if so, did they treat it? And we're kind of stopping the algorithm there because our goal is to just make sure that our nurses are following what the algorithm is. Are you doing the things that you need to be able to do? But from that, we can then take that information and be able to dissect it out for whether or not it got treated for the rest of the stay, what happened with the patient, and all of that, because we can identify who they are.
And so you're pulling 10 people who already have some sort of gestational hypertension, preeclampsia, or eclampsia as a diagnosis. That's how you can get those first 10 charts?
Correct. So they're already in the hospital for that diagnosis or have been, because we're definitely looking at it and post-discharge patients. It's not active while they're here in the hospital. And then we just look to see, did we meet up to the metric? Are we doing the things that we're supposed to do from a nursing standpoint to try to be sure that these patients are getting the care that they're supposed to get?
Thank you so much for sharing. How long have you been doing that?
Initially, I started doing it and tried it for 3 months, looking for myself on a small scale, and I started that last June. And then I gave it over to my audit person who comes in to just work audits for me. She's a retired nurse for almost 40 years, and so she comes in and just looks at charts for me to try to be sure that we're moving our practice forward.
Got it. Thank you for sharing.
You're welcome.
Mm-hmm. I'm aware of the time and aware that I think that we could have a longer and really rich conversation about this topic. Laura, just looking at the time, I think probably maybe we want to find another to devote some time, and maybe we can, those of you who are on the call who have a process that haven't had a chance to talk about it yet, maybe we might ask you to share those. Kind of we could do that as on our next webinar, and then help each other move forward on this. How does that sound?
I think that's great. We will definitely have time in February. So if there are others who could take time to prepare just maybe a summary of what you're doing in advance and share it with the group, I think we could all benefit from hearing everyone's experiences.
For sure.
Okay, well, just moving along, I have 2 very quick updates. The first one is about implicit bias training. What's the next slide, so you can see it? So we're working with the Institute for Perinatal Quality Improvement to offer the implicit and explicit bias Speak Up one-day training. We hope to offer a couple beginning late spring or early summer of this year for a large group of about 100 participants for each training. So stay tuned for more information on that. We're currently working on it. And we're also working with the perinatal outreach educators to host regional trainings across the state. We're looking at about 5 locations. And during the training, we'll offer high and low-tech simulations, and we'll standardize that curriculum for each site. Same time frame, late spring, early summer of this year. So we're excited about both opportunities and look for more information to come. And to save the date for our annual conference in April, that is it. I really appreciate y'all's time today and patience with me and the technology. If you have any final questions, feel free to email me. It's laura.lane, L-A-Y-N-E, and our next webinar is February 4th. So thank you all so much, and we will talk to you in February.